Welcome to Let's Talk, a place for straight talk, hard topics, and smart people. I'm Sue Wallace, CEO of Oximetry, and thanks for joining me today. I'm very happy to be here with James Crowley and Dustin Osborne to talk about radiopharmaceutical therapy in the clinic. So for both of you, what are you doing? One of the hot topics in every discussion is, even if people are thinking about dosimetry and I can't do it because I can't do more imaging, or how many time points, is my one time point enough? Maybe it depends on the pharmaceutical, but what do your protocols look like?
Well, so for us, we sort of tested out which range of multiple time points we wanted to use. So we actually, on the first doses that we did, we went through and did a study on 2, 3 time points, 4 time points, and looking at what that was and how much it actually impacted if I changed to 2 time points, for example, and how much that changed what my calculation really was at the end. So we really settled on again, trying to balance between what's reasonable for the patient, what is acceptable from a clinical billing perspective, because you don't want to overbill the patient for something that is also not super helpful. So we settled on doing a 2 time point, we do multiple time points, but for the first dose, we actually do a post-therapy imaging 2 to 4 hours after, and then they'll come back 5 days later, so we get a late time point methodology, and then we calculate out their effective half-lives, and then from there,
pretty early and pretty late.
Yeah, pretty early and pretty late.
Is that good or bad? From a patient perspective is really my question. They still have to come back, but is it almost better if they come back, they've got a couple days break between? Or, I think you both have patients that come in from pretty distant territories, right? So then they just come, but they come back, they can fly?
They do come back, and then the initial after is just so we have some confirmation everything went correct, right? That we didn't have something like an extravasation, or they don't have some weird physiological thing that has changed over the last 3 months since we did the PET scan, and it's sort of checking that that's there, and we also get sort of a peak level to initially start with for our exponential curve, right? And then the 5 days is nice because we are in that later. We know that there's typically two, early fast clearance, and then there's a late slow clearance, and so we want one time point at least in that early fast, and we want another one that's in the late slow. And so that's what we're trying to target. And that seems to work reasonably well. We only do that for the first dose. And then as long as the patient's labs hold pretty steady, so their GFR holds and the liver enzyme or liver function labs come back similar to what they were over time, and we sort of apply those effective half-lives we calculated from the first dose, and we project those through the subsequent doses, unless we see something clinically that guides us to, okay, well, you need to come back for another series of events.
And this is for your lutetium patients primarily, right? Obviously, it's a different story for Y90s, right? Yeah. So what are your thoughts on lutetium protocols?
Yeah, to be honest, I plan to mirror his protocols, so, he is further along in this. And as we bring this back into our clinical practice, I've talked with folks from Germany, Australia, that there are standards, but nobody seems to follow them. So I think at some point you have to start standardizing. And frankly, we don't care. So why not? In our region, we're trying to even come up with potentially ways that we could do single time point. But we have to gather the data and the norms of our we don't have, as he likes to say, we don't have California vegans living in Tennessee and Southwest Virginia. We just don't, right? And so coming up with the typical biodistribution for the people that travel in, and say, hey, we are just going to do the one time point, and this is our best guess, but this is what we're doing. If you want to come back on day 5, please do. Otherwise, if you're flying in from Florida, which happens to us too, they don't want to fly back on the fifth day. Right. So I think as we work through that, there's a lot of we can do better. Yeah. At some point, we have to start to standardize, whether it's the perfect answer or not.
Let's say, so if you follow his 2 time point protocol, but you've got patients that's just not going to work for. They're not coming back 5 days later for whatever reason. Then do you say this is our protocol, 2 time points, and you just make an exception for certain patients? Is that kind of how you would manage that, or how does that affect your thinking about it?
Yeah, I don't think we've answered that question yet, but I do. What we are going to do is actually allow patients to opt in. We are not going to say that this actually changes your course of therapy because we don't believe it's true. We're going to say to patients, if you want to know what your organ dosimetry is and your safety profile, just in case you live a long time and you have a need for radiation oncology or whatever in the near future, if you want to invest that time, we will provide those resources to you. And that is how my physicians also got on board, because they actually really don't. We're an accountable care organization. I can't tell them this benefits them. At least I don't believe I can yet, or they don't believe they can yet.
Yeah.
That the data on that may be growing,
Yeah.
but for their perspective, it hasn't changed. They did the review. They had 0% changed what they would do. That doesn't mean they're right. It means that they don't really have the tools to get the doses they want. So I think our opt-in approach it's for the patients, that means they're going to be more willing.
Yeah.
This was your choice.
But this depends,
know?
doesn't it? I'm going to ask Dustin if he knows how these conversations go at your site.
Well, he does them, I think.
Yeah, well, but I mean, because most of these patients are scared, and they trust their caregivers, and they say, well, whatever you think I should do, doc. And then we say, well, we can't really tell you. It's your choice.
Yep.
And so it is a little bit so they say, well, how does it really matter? Kind of, that's the patient question. So I think, because we see variability, some clinics say, well, we have a hard time getting them to come back and others don't. And I wonder sometimes if it's that they're not, willing to, they just do leave it to the patient, and it's hard to maybe have them appreciate the choice they're making. I mean, how do you see your conversation?
I mean, the way that we do it is that we start that conversation at consultation. So when we are consulting the patient, which is usually my staff, me, and the AU in the room with our patient, and we're having that discussion that, we want you to come back, right? And we don't say anything about that this is going to change your management of care or anything like that. It purely is
You're not saying you have to, but you do say, we want you to come back. So that's a really good.
Purely about the record, that we want to know where this went. We want to know that we did a good job, and we want to know what radiation exposure was there for your organs. And I have not yet, that's inconvenient. And nobody's like, yay, I have to come back 5 days later. But not one person, even ones driving from 2 hours away, have said, I'm not going to do that. Not one.
Right. And these are pretty sick people. By the time you're in these lutetium cases, they've failed everything else for the most part, right? So that they know there's a lot involved. They know all those steps matter. They're pretty committed. And so I would think that they're also very sick. So if they can't, they can't. You mentioned your fatigue, your patients with extreme fatigue. Are they just not able sometimes? I mean, has that been an issue?
No, they come. I mean, even the one that we had a couple that really just could not move hardly. And those, they came back in 5 days later. A lot of times the fatigue really doesn't pop up until after that 5-day mark, to be honest. I mean, it's they'll be tired at 5 days, but sometimes it's 7-10 days out before they really sort of drop off. And that's where again, another thing with the dosimetry is when we see that in patients, you start to think, well, is there some sort of predictive formula we can come up with if we understood this better? And if we don't have that data, then there may be a nice algorithm we can come up with that says if you've got this, this, and this, you're going to be tired. And at least there's not a whole lot you can do about it. But maybe we can do something, electrolytes, or we can do something that's just something. Yeah, that you go ahead and plan a transfusion, have them sitting there. What's going to happen, so let's bring them in. And be more proactive about the care, I suppose. And that's something that we're working on, is trying to build up more infrastructure around it, not just our physics components and our imaging components, but the whole care plan around dosimetry, and coming up with ways that we can make that more comfortable for the patient.
Well, it's funny on dosimetry. I mean, because nobody would I don't think people who are doing, the wide 90 microspheres, whether it's either of the vendors that are currently available, they wouldn't dream of not imaging that. But there's not a thing they can change. They've done what they've done. And that patient does not have a long life expectancy. So it's like, in the idea, we have to change our thought. Everybody wants to know what's happening with the wide 90 microspheres. But, frankly, these patients pass within 6 months, typically. So you're not going to likely give them something else, but it doesn't, it's the same problem with the Pluvicto and the DOTA. Like, we still should know.
James and Dustin, I hate to stop this conversation. There's so much here to learn from what your in the clinic experiences are. This has been great. We may have to do this again, but thank you so much for joining me. And so that's my official close. Let's talk again. Yeah.
Very good.